Good afternoon, everybody, and welcome to our July 2026 APIC Great Lakes virtual education session. Today, I am very excited to welcome two amazing members of the Duke Infection Control Outreach Network to present on infection prevention in ambulatory care. With us today, we have Brittain Wood and Valerie Payne. Brittain holds dual Bachelor's of Science degrees in microbiology and professional nursing and has served as a practicing infection preventionist for 14 years in North Carolina. In this role, he has experience in a variety of care settings, including acute care, long-term acute care, inpatient rehabilitation, and ambulatory care. He joined the Duke Infection Control Outreach Network in September of 2016. Congrats on almost 10 years there, Brittain, to provide expert consultation to community hospitals and ambulatory healthcare settings. He has been board certified in infection prevention and control by CPHQ since 2013. Additionally, Brittain is an active participant in the Association for Prevention Control in Epidemiology, and especially in his North Carolina chapter. Personally, he enjoys traveling and maintaining an active lifestyle as an avid runner. Valerie holds a master's of public health and has served as a practicing infection preventionist for 14 years in Texas, Arizona, and North Carolina. In these roles, she has experience in a variety of care settings, including acute care, long-term acute care, inpatient rehab, and ambulatory care. Valerie joined the Duke Infection Control Outreach Network in December of 2021 to provide expert consultation to community hospitals and ambulatory healthcare settings. She has been a board certified in infection prevention by CPHQ since 2014. Additionally, she is an active participant in APIC, especially in her North Carolina chapter. She enjoys spending time with her dash hounds and traveling with her spouse and friends, is an avid scuba diver, and loves exploring underwater landscapes. So please, everyone, give a strong welcome to our two amazing presenters today. Before we let them take center stage, I did want to announce that everybody should be checking their emails because Save the Date officially has gone live. We have our APIC Great Lakes 2026 Fall Conference coming up in October 15th. The Give Butter link for signing up for the conference has officially gone out. That went out yesterday. Kelsey put that in the chat for everyone. And it's going to be at the Kellogg Center this year. Registration fees are $85 for members and $110 for non-members. And all those in attendance will be eligible to receive 5 infection prevention education credits. And as always, please make sure you are following APIC Great Lakes on LinkedIn. If you are in the job market or know somebody looking, we always try to share from our hospital teams and other organizations different job postings. These are two of the current ones that have been posted. And last but not least, if you would like to catch up on any of our back catalog, please feel free to find us on YouTube. We are APIC Great Lakes together on YouTube, and you can find our entire back catalog there. I will stop sharing my screen and I will pass it over to Brittain and Valerie now to take us away. Thank you so much.
Thank you so much for that warm welcome. We're excited to be here today with you all. We're going to go ahead and let Valerie start. She's going to drive the slides for us and kick us off.
Okay, can everyone see our slides here?
We can.
Yes, we can.
Excellent. Well, thank you so much for having us. I do appreciate the warm welcome. And if any of you attended the national conference in Nashville this year, you may have seen this presentation. So just advanced notice there. But we are excited to share our experiences with ambulatory care, and we'll kind of jump right into the objectives. The first one is to describe an ambulatory infection prevention program model, including applicable regulatory requirements, surveillance activities, and risk assessed priorities. Secondly, we'll discuss methods for strengthening top-down and bottom-up engagement that supports an IP program in this setting. And along the way, we're just going to share policies, risk assessments, our tracer tools, other resources that we've developed. And we really hope that it accomplishes these objectives by sharing with you a organization's journey to standardize key infection practices across a large multi-specialty clinic practice that we've worked with. So before we get started, I'll just provide a little bit of an introduction to our network. DICON is an acronym for the Duke Infection Control Outreach Network. It was formed to advance efforts that improve quality of care, enhance patient safety, and minimize costs by using evidence-based approaches to infection prevention. Our network is a collaboration with more than 60 community hospitals, surgery centers, and ambulatory care practices that stretch across 5 states from Michigan to Georgia. So I'm actually responsible for a facility that is UP Marquette in the Upper Peninsula. And our goal is to work with infection prevention programs and partner with local teams to strengthen practices. So just about this particular practice that we're going to talk about today, in November of 2021, DICON services were contracted to assist with a large ambulatory multi-specialty practice. In this practice, there's over 100 physician-run clinics, and there's just a whole lot of disciplines in this group. They have dermatology, obstetrics and gynecology, ophthalmology, ENT, gastroenterology. So you can see a theme there for these specialty practices that are pretty complex services provided. We're going to see lots of high-level disinfection and sterilization in these clinics. And now I'll turn it over to Brittain.
Great, thank you, Valerie. So keeping with the span of the clinics under this practice in mind, let's start with some applicable regulatory standards and those program structure needs for this type of ambulatory healthcare setting. So here we've listed some of those pertinent regulatory agencies for ambulatory care, and of course, always applicable CMS standards should be considered. And then additionally, because our home base is in North Carolina, there exists requirements for ambulatory infection control programs and training under state law. This North Carolina legislative code has 2 primary requirements. One, the rule requires any healthcare organization that performs invasive procedures, that would be including injections, to have a written infection prevention policy. And secondly, they must have a designated on-site staff member with state-approved infection control training, and they must have a staff member that's assigned for each non-contiguous facility. So we're a little unique in having that law in North Carolina. In some cases, ambulatory care sites may also opt to obtain those external accreditations from organizations like the Joint Commission or the Accreditation Association for Ambulatory Care, which we commonly refer to as AAHC. In our experience with this particular practice, North Carolina's 0206 requirements and this particular practice is also Joint Commission accredited, so those standards apply as well. And of course, that was one of the drivers for bringing DICON on board, was to help prepare for their expected triennial survey, which was scheduled for that fall of 2022. So as I mentioned earlier, as DICON IPs, we were asked to support program functions in November of 2021. And our first task really was to conduct a gap analysis. At that particular time, the full-time infection prevention manager had accepted a new role, leaving the department without a dedicated IP. And further, of course, the demands and resource prioritization incurred by the pandemic had resulted in some coverage gaps. So a little more history. In 2020, no infection prevention tracers were documented. From January through October of 2021, only 4 tracers have been formally completed by a trained infection preventionist. Additionally, the organization had a wonderful program for frontline staff engagement through assigned infection prevention liaisons at each clinic, and Valerie will talk about that in a minute. But over the course of the pandemic, of course, staff turnover, clinic acquisitions, leadership changes, liaison reassignments, routine connections with those liaisons was lacking. So from the beginning of the work with this group, it really was evident that the previously laid IP program foundation was strong, but it really was in need of some refreshment. So looking at those basic requirements for program composition, we noted the IP plan lacked some key features. It did not clearly delineate program functions, role responsibilities, or reporting structures. With that, an annual risk assessment or program evaluation had not been completed. And of course, limited data were available from which to base an annual evaluation or risk assessment on from that previous year. So we also look to prepare for the organization to hire a new full-time permanent infection prevention manager. And on this, there wasn't an existing orientation plan for someone assuming that role. So in terms of the general programmatic elements, we felt like we had to start from the beginning by building a strong foundation. So to help us illustrate how we developed the annual documents when we didn't even have much by the way of supporting data, we wanted to share a few example documents with you all. As with acute care infection prevention program policies, the ambulatory IP program document outlines those key functions, including, of course, an authority statement, reporting structure, role responsibilities, program resources, surveillance activities, communication and plan implementation strategies. And here we worked with the quality and safety leadership teams for a better understanding of those committees, including participation and representation, and where infection prevention data and PI activities really are presented. We were on a fact-finding mission. But through this process, we also learned a lot about how occupational health concerns were handled and who was responsible for communicable disease reporting and generally how to navigate those frequently asked questions posed by the clinic staff. Next, we tailored a risk assessment for ambulatory care. And of course, for many of us with experience in acute care hospitals, our risk assessments may include outcome measures derived from our HAI surveillance activities like CLEPSI and central line insertion bundles, or VAE and ventilator management processes. But our ambulatory risk assessment was organized around the Joint Commission ambulatory standards and specific elements of performance. And we centered this on the infection prevention processes like hand hygiene, low and high level disinfection, and sterilization. To make things as streamlined as possible, we adopted an all-in-one program evaluation and annual plan document that mirrors the risk assessment's design. It is organized by Joint Commission standard and includes those identified risks. These prioritized risks were highlighted in yellow. And next, the individual goals and interventions to address each risk was described along with the responsible parties. And so at the end of the first year, we used the final column to evaluate each element of that plan that we developed. So kind of after level setting the program's core administrative documents, we began to prepare for the eventual onboarding of a new IP. An orientation and competency document was tailored to the needs of ambulatory infection preventionists. The orientation also conforms to the competency domains outlined by CPHQ. And you can see those listed there. And this is an example really of the first page of our orientation competency tool. We also included even basics just for a successful start to the job, like access to your shared drives and voicemail setup. We also recognize the importance of ensuring the new IP would be plugged into the infection prevention world through APIC and other relevant groups and subscribe to listservs to help keep us up to date. And so when considering what to include in an ambulatory IP competency, it's important to consider the organization's scope of service and the professional needs or requirements for that IP. For example, there may be a requirement for CIC certification, in which case all competency domains may need to be addressed, even if some elements are unlikely to be encountered in those day-to-day work with clinics or are not supported part of the IP's core responsibilities. These may include certain surveillance activities and statistics or even employee health.
All right, thanks, Brittain. So now that we've laid the foundation for that administrative side of the program, we'll talk about how we framed this program with three core components. And that structure included our frontline clinic champions, a strategy for basic infection prevention training of those champions, and then really revamping the hand hygiene program. To start, our frontline champions are called Infection Prevention Liaisons, or IPLs for short. This was an established program with this group that dated back to 2017, 2018. But like Brittain had said, it didn't receive much love over the course of the pandemic. So by the end of 2021, when we came on board, there were less than 25% of clinics that, I should say about 25% of clinics that didn't have a designated liaison. And so we really wanted to make some concerted efforts with clinic leadership to identify volunteers to assume this role for clinics that didn't have an IPL or to re-engage the existing liaisons. That was especially important to comply with that 0206 North Carolina Administrative Code that Brittain talked about, where each clinic has to have a designated individual trained in infection prevention practices. Often these IPLs are filling that role. They're the go-to resource for their peers in the clinic, and they're the designated individual oftentimes to collect those hand hygiene data, and at the time conduct semi-annual mock surveys using our standard tracer tools. Fast forward to 2025, that pie chart on the right is just showing that 91% of clinics now have a designated IPL. And this is something that kind of constantly takes some vigilance to make sure people are recruited into this role. One way that we do that is by developing a clear, defined role description and responsibilities form with an appointment timeframe. So we'd heard from folks that said, I've been an IPL for like ever, and it is a volunteer position. So this role, doesn't come with any sort of financial compensation. So we wanted to be very clear about what their responsibilities were, that when they decide they'll do this, they'll do it for a minimum of a 2-year appointment. They can do it longer than that if they choose. This helped them understand what to expect and also how it might benefit both their respective clinics and their personal professional development. They can use it in their performance evaluations and their clinical ladders if they're working up to that. So we really use this as a way for clinic leadership to promote the job and for quality and safety leaders to incorporate recruitment into annual skills fairs and other ways to get IPLs engaged. As we revitalize that IPL program, we also acknowledge the need to provide this 0206 infection control course for outpatient healthcare settings on a routine basis. So here in North Carolina, the UNC's statewide program for infection control and epidemiology provides this course at some cost usually to folks who want to take it, but they also allow for approved course instructors. And so Brittain and I were eligible to become instructors for this course. And so in 2022, we set up quarterly virtual offerings and posted the links on the clinic practice internet page so that by the end of the year, we'd enrolled nearly 100 staff. And we were on target for each clinic to have that designated team member with this basic infection prevention education. We continue to provide this outpatient course to clinic staff and also to our broader DICON network at this point. We do it twice a year through DICON. And our most recent course in March of 2026 had 111 participants. So we still see quite a lot of demand, not only from this individual practice that we're talking about today, but across our network. And then our third component was this hand hygiene program. So we wanted to know, who was responsible for collecting these observations? What exactly were they observing? And where could clinics find information about how their clinic was doing with hand hygiene? And so with data collection goals, we said, well, we need to kind of think about what we want people to do so that they know what the expectation is. So that was the first step. We said we want each person collecting hand hygiene data to submit at least 10 a month. And ideally, you would have 2 trained observers in your clinic. So top line goal would be get at least 20 observations a month for that clinic. In some places, that's not too hard to do. In our really tiny clinics, that can be a little bit more difficult. And then just giving them some hand hygiene training, and a standard observation tool. With those data goals set, you can see that in 2021, we only had about 40% of clinics that were reporting any data, even one observation the entire year we included here in this. And then last year, you can see upwards of 80% of the clinics are routinely submitting hand hygiene observations. And then for the practice on the whole, you can see the total number of observations submitted by year, where there was only about 12,000 in 2021 and 2022 submitted. And then once we revamped this in 2023 and we've maintained and continued to give feedback about submission data, that has really jumped in the most recent few years. The revitalization of the hand hygiene program included conforming to the health system hand hygiene policy and simplifying the observation tool. So in the previous version of how people were asked to do this, the data entry form included all 5 moments for hand hygiene, and data collectors were asked to trace the patient from the start of their encounter to the end of their visit. And so it would take the data observer out of their routine workflow to have to stop and follow this process of watching the patient through their entire visit to try to capture all 5 moments of hand hygiene opportunities. So in the new system, staff observe for before care and after patient care. And then lastly, we noted that the health system was using really pretty solid software that allowed them to do electronic data entry and have really nice dashboards and the ability to see their data real time as it was entered. And so we wanted this group to transition to using that software system. So I'll just pause here. This is our hand hygiene tool that was used as kind of a training for those data collectors. The paper tool is voluntary. Most people don't do that. They enter their data directly into the electronic data entry form. And then here is just a de-identified view of our hand hygiene dashboard. So there are many ways the team can stratify and analyze their hand hygiene data. We like this heat map. Across the top, there are overall compliance scores and the number of submissions. And then the heat map reflects scores for a specified time period for each clinic. So those that are under 95% compliance are in red, clinics scoring between 95 and 97% are in yellow, 98 to 99% are green, and then anybody with 100% has a blue tile. And then, so to sum up what we've talked about in this framing of our infection prevention program structure, we worked closely with each clinic to engage a dedicated IPO. We offered accessible trainings on routine, timely intervals, and we looked for ways to improve and streamline their hand hygiene program. And one helpful tip, is to think about ways that you can partner with others, especially if your ambulatory clinics are part of a healthcare system. We saved a lot of time by not having to recreate the wheel, and we were able to get the ball rolling on multiple fronts in a relatively short period of time by using some of those health system resources.
Great. So as we described with the risk assessment and evaluation, ambulatory surveillance really does take on a bit of a different look in the outpatient environment compared to acute care. So rather than focus on NHSM protocols and HAI surveillance in our clinics, we focused on infection prevention processes. So in this section, we're going to cover how we organized our tracer activities, the tracer tools we developed to assess the clinic practices, and some of our findings and performance improvement initiatives that were started to address deficiencies. And we've also included some pictures, which is always fun. So with our primary experience being in community hospitals, we did have to reimagine the term surveillance as we were no longer looking at microbiology reports and daily lab surveillance in the traditional sense. So in the clinics, we considered monitoring key processes to be surveillance activities, as well as infection control related safety reports that were submitted. And then another potential source for surveillance and outbreak management could be upon notification of complications from personnel at other facilities as well. As we, continue to describe our experience with this large clinic practice, initially we really did need to get our arms around the breadth of the program, the number of clinics and their respective locations, reporting structures, in-office activities such as device and instrument reprocessing. So through existing databases and by querying clinic leaders, we learned that nearly half of those clinics had some sort of what we consider high-risk reprocessing activity. So looking at a multi-year review for the number of primary or general infection prevention tracers that were completed by a trained IP, we could see that in 2018, over half of the clinics were visited. There was then a sharp decline in 2019, none in 2020, and only a few were done in 2021 before we were brought on. So with this in mind, we prioritize those clinics with reprocessing responsibilities. We also work to get the most bang for our buck, right, by surveying clinics within selected geographic locations to prevent excess transportation between clinics. And so within the first 6 weeks, actually, from mid-November through December 2021, we were able to visit 22 clinics. From there, we decided to set a goal for annual tracers for clinics without high-risk reprocessing activities and semi-annual tracers for those who perform high-level disinfection or sterilization. And so by visiting clinics every 6 to 12 months, we've been able to form those valuable, trusting relationships with staff and clinic leaders, and they really do look forward to seeing us. So here we want to just share with you all some of our clinic tracking tools. It's not fancy, right? But I think the benefit of this is that we can sort the clinics by address or zip code to help map out our routes. And that really does maximize our time on tracer days. And you can see moving to the right, we've also built in columns for clinics to indicate whether they were doing high-level disinfection or sterilization and some more details about what those high-risk reprocessing activities entailed. So we can also sort the clinics by their high-risk reprocessing activities. And so as we got out there and we evaluated the practice, we noted wide variations in high-level disinfection chemicals in use, as well as various types of tabletop autoclaves used for sterilization. So in this little snippet, we've limited those to clinics that perform high-level disinfection. And you can see we had 3 types: orthopentaldehyde, peracetic acid, and bleach were all used as some form of high-level disinfectants within this practice. And so that really got us thinking, right? Like that it pushed us to pull those instructions for use and product specifications for each product to ensure that we ourselves were going to be performing their tracers accurately. And so that really got us to think about adding a tab to our clinic tracking tool. And this is really, I enjoy it a lot. It contains those basic details for each chemical we found in the field. And so barring the memorization of all of these elements for each disinfectant agent, we found having an easy reference tool made assessing compliance easier. So we could just take a little peek at this, get that in our brain about, do you need a test for conformance? When do your test strips expire, et cetera. So we'd have that information ahead of time. So now on to the fun part, our tracer tools. So for those of you who may have access to Joint Commission resources, they do provide canned IP tracer tools. But however, you can develop and create customized tracers to fit your organization's specific processes and needs. And so in our case, the general IP tracer includes items such as hand hygiene practice, PPE use, supply storage, safe injection practices, medication and lab refrigerator maintenance, environmental cleanliness, and staff knowledge of core infection prevention practices like communicable disease reporting, managing patients who might require some form of isolation, and how to report suspected infection-related complications. And so with Joint Commission resources, reports are also easily generated by clinic or a specific group of clinics. And so one of our favorite reports to run is a top 10 findings report. And while we had limited data in 2021, we did see a shift in the type of deficiencies we observed comparing 2021 to 2022. So 6 of the top 10 findings in 2021 dealt with medication and safe injection practices. But by the end of 2022, nearly all of the medication-related items had fallen off of that top 10 list. And so on this slide, we have our most recent findings from 2025. And most findings now are related to, as you can see, environmental cleanliness. Multi-dose vial labeling still makes the top 10 and is always a focus for our team. We just cannot shake that one. But positively, the percent compliance for multi-dose vial management in 2022 was 85% compared to now it's 95% in 2025. So that does highlight some considerable improvement. So we'd be remiss not to share some photos, right, taken during our rounds. So just want to highlight a few of the things that we found during our first year with this particular organization. As is so often identified, storage of patient care supplies offered some improvement opportunities, like removing outside shipping boxes from clean utility rooms and ensuring solid bottoms on wire racks. In some areas, mounted sharps containers were lacking. In their place were sharps bins, sometimes overfilled, that were just sitting right next to the sink and could be easily tipped over, like in that far left picture. Another unique finding that stemmed from our supply chain shortages during the pandemic was unapproved soap, sanitizers, and lotions. We even found an alcohol-free sanitizer in one clinic's exam room that had been so kindly donated. Other low-hanging fruit for the environment of care were those daily refrigerator temperature log documentation, open lids of low-level disinfectants, and staff knowledge of contact times, especially when a number of products were present due to supply availability. So on the medication front, we uncovered opportunities related to injectable medication vials. There were several instances of single-dose vials being used for more than one patient and multi-dose vials that were unlabeled or past their 28-day expiration. We found pre-drawn syringes without labels of contents, date and time of preparation, and we also found multi-dose vials with spiking devices left in place for later use. Lastly, medication storage was not always compliant with standards and organizational policy. Medications were found prepared in clinic exam and procedure rooms rather than in a dedicated clean medication preparation area. So in collaboration with clinical education, clinic leaders, and their quality and safety team, a major focus was placed on the highest risk findings from the primary infection prevention tracers. Medication prep and administration resources were broadly shared, and safe injection practices were highlighted at their annual skills fair.
Thanks, Brittain. So now we'll kind of turn our attention to our high-level disinfection tracer. So we developed two customized tracers designed specifically for instrument reprocessing in ambulatory care. The first is this high-level disinfection practice, and the second tool assess sterilization. This is a sample of the high-level disinfection tool, which takes you step by step in tracing a semi-critical device through each reprocessing step. The tracer tool is divided into sections such as pre-cleaning, PPE usage, the reprocessing environment, instrument transport, leak testing if it's applicable, manual cleaning, again, the use of flushing aids and brushes if applicable, high-level disinfection, either manually or with an automated endoscope reprocessor, followed by rinsing, drying, and storage. And lastly, the tool also asks questions to assess high-level disinfection documentation, endoscope repair, and equipment maintenance. The top 10 finding report shown here was from 2025, and these are results from our tracers from last year. And as you can see, there are some opportunities identified surrounding AER maintenance, in particular filter changes for our water filters, preparation of high-level disinfection solutions, whether that's Cydex OPA or Maxicide OPA or any one of those other solutions that Brittain shared earlier from our clinic catalog, and then monitoring of minimum effective concentration and documentation of that testing of the high-level disinfectant solution. And then lastly, we also had device pre-cleaning show up on our top 10 findings report last year. So some of the things that we really kind of focus on are quality assurance of our high-level disinfection test strips. We wanted to make sure that we had concise logs for accurate documentation, and that reprocessing was done following all the required steps, particularly for endoscopes. We spend a lot of time with endoscope reprocessing because we just know it's so complicated. And before I kind of dive into what we saw in some of these pictures, I do want to note too that we have some practices within this group that are community practices that come into this larger health system umbrella who had never been externally or third party accredited, and kind of had been physician-run practices that were under a new set of regulatory standards. And so what I'm going to describe, particularly in this first picture on the left, is a situation where when we did go out and find these things, this clinic's practice was halted for reprocessing of flexible scopes, and they used disposable scopes until this system could be brought back up safely. So when you see this, I'm just mentioning that as infection preventionists, there are times where it really is important for us to engage the chain of command and your leadership to say, well, this really is not safe and we're not able to turn this around in a day. So what are some things that we can do in the meantime until we can make sure that all of these steps are followed properly? So in that left picture, we had all kinds of things. We had hand soap that was above our reprocessing sink. Our eye wash station was connected to our dirty sink. There are so many items that are in the splash zone. In that green bottle was pre-mixed enzymatic detergent, but we had no idea what the dilution ratio was, and neither did any of the staff. There was no thermometer for measuring the temperature of either the enzymatic detergent, which this particular enzymatic detergent required, and there was also no thermometers to check the temperature of the high-level disinfection solution, or they weren't logging those temperatures. They also on the wall on the right there of that left-hand picture are 4 acrylic cylinders that they were using to place the flexible scopes. This is an ENT clinic. They weren't completely immersing the scopes. They were just putting the tips down into the solution. Those containers were not clearly marked with when the solution had been poured or when it should be discarded. There was no clear evidence that they were timing the duration of time the scopes were being put in that solution, and MEC checks were lacking. And then finally, just from a reprocessing space standpoint, they also had these biohazard bins directly underneath those solution canisters or cylinders there. And so everything was just very tight and not in a great dirty to clean flow. We also couldn't find good evidence of how the scopes were then rinsed when they were removed from that solution. So for all of those reasons, we said, wow, we have to really put a pin in this, move to disposable scopes for a while, and then readdress. In the middle picture, you can just see it's not a great dirty to clean flow where we have some instruments that were laid out to dry that are underneath those blue chucks pads, but right over that is your specimen window that they're going to be pulling out and then doing that point of care testing there in the middle. And then on the right, we have clean, flexible scopes that were pre-staged in transport containers and then distributed to all of the rooms in advance of what they perceived to be a clinic day that was quite busy. And in this case, they even put that clean scope right on top of the hand washing sink. So as noted, there's often several opportunities with workflow within the reprocessing environment. And sometimes, developing that dirty to clean workflow is a challenge because we have so many space restraints in some of these spaces. But a key area to highlight is just ensuring that infection prevention representation is there for new build construction or any existing renovation projects, or anytime somebody says, hey, I think we can open this clinic in this building and start doing fill in the blank procedure with fill in the blank instruments, because our eyes to kind of help guide how these rooms are set up is really important. So there's an example of what we think is an ideal reprocessing room, and it moves from dirty to clean quite nicely. On the left, we start with a dirty or manual cleaning sink. It's separated by a splash guard, so we get to retain all of the use of the counter space to the right of that, where instruments are laid out to dry and inspected. They're put in the autoclave. There's a nice place for sequestering instruments before the BI is read out and documentation. And then our clean hand washing sink is also separated by a permanent splash guard to prevent any water contamination to the left of that sink. And then, as I've mentioned, one of the more challenging obstacles that we had to wrangle was just the variation in existing logs. High-level disinfection practices can be very complicated, as we all know. And with over 100 clinics in this group, half of them were performing some form of reprocessing. And so the challenge was to develop tools that could be applicable across all sites and then took into consideration all types of devices. So on the right is just a list of the logs that were developed specific for high-level disinfection. And we provided, samplings of those logs for review. First is our enzymatic detergent temperature log, which you may or may not need to have based on your facility's policy. Then we tackled endoscope reprocessing in an AER. And another complicated factor was that some of our AERs had downloadable data where the reprocessing data was downloaded for later viewing, and then some did not. So if not, the HLD AER with downloadable cycle data was eliminated. The need to include the NEC requirements for the HLD solution. The data was available electronically. So there were just lots of variation to these logs based on what they were doing. If they had a flush thingy device, we used this. If they had an endoscopes that needed to be logged for repair and preventive maintenance tracking. Again, if they had an AER, they needed to be keeping track of their water filter changes and their water line disinfection. We also have manual high-level disinfection going on, as you saw in those pictures. Some of our ENT clinics, our ophthalmology clinics will use these logs. And then we also have trophons, so both the current model and the older model. So there's a couple of different trophon models. So we just work really closely with clinic leadership to say, okay, here's what you have and here's what you're reprocessing. And therefore, these are the select logs that you'll need to use. And that just goes into part of the training. I'll turn it over to Brittain for
Valerie,
sterilization.
I do think the fun we had with the log standardization was a heavy lift, and we had times we didn't think we were going to get through it, but we did.
True.
And we made it happen. So, like Valerie mentioned, in addition to our general IP tracer, we developed those two high-risk reprocessing tracers, one for a high-level disinfection, and here we have one for sterilization. This is an example of that tool, and it again takes you step by step in tracing a critical device through each reprocessing step. This tracer tool is divided into sections just like previous ones, such as pre-cleaning, PPE usage, the reprocessing environment, instrument transport, manual cleaning, package and assembly of those instruments, sterilization wrap or containers, sterilization parameters, and quality control indicators such as your BIs and your chemical indicators, and then of course lastly with storage. So once again, this is the top 10 findings report from results of our survey using that sterilization tool. As you can see, there were some opportunities identified surrounding sterilization documentation. So here specifically lot numbers of the biological indicators, load number, results of both the control and test BI. We had opportunities with peel packed instruments as well as with autoclave maintenance. So as we continue to drill down on some of these focus areas related to sterilization of critical items, we primarily focused on preparation of that enzymatic detergent during manual cleaning, package and assembly prior to sterilization, and the importance of documentation for both the test and the control biological indicators. Just as we saw with HLD, preparation of that enzymatic detergent prior to manual cleaning was a focus. We wanted that correct ratio of water to enzymatic detergent. We also found many pill pouch instruments that were in the closed or latched position or lacking a chemical indicator. Several clinics were also incorrectly labeling their pill pouch items or overloading them with 6 or 7 or 10 or 12 instruments. And then the third area of focus highlighted on documentation, understanding really of what a biological indicator was and to correctly document the results of that biological indicator. So here are some great examples of what we found while conducting the sterilization tracer. In the left picture, you can clearly see the issue, right? We have some water stains. I believe there's some yellow instrument tape there, and we have writing on the porous side of that peel-packed item. We found several clinics who needed re-education on ensuring that the hinged instruments are in the open position. Fortunately, in this example, they were. In the middle picture, our sink is backed with incorrectly prepared enzymatic detergent. In fact, this detergent, I believe, was prepared at the beginning of the day, and stainless steel instruments were placed directly in that solution throughout the day. Prior to the end of the workday, staff would then utilize their reusable, not disposable, brush to manually decontaminate those items. Um, and we still have pre-prepared enzymatic detergent in a non-manufacturer approved dispenser. You can see that eye wash was attached to the dirty sink, and supplies for hand hygiene were at that decontamination sink. The third picture is from an ENT clinic where rigid scopes were found stored in their original container. We didn't know whether these were clean, whether they had been sterilized, but clearly they're being displayed very nicely on that fresh foam. So just as with high-level disinfection, we found documentation challenges with our critical items that underwent sterilization. Once again, here's a sample of the enzymatic detergent temperature log. There we go. This log was implemented to ensure staff who prepare the detergents were prepping and using and documenting the solution at the appropriate temperature range in accordance with the manufacturer's IFU. The next log we have is our standard sterilization log to record all of the necessary components required for items that undergo sterilization. And so here we're looking for the autoclave ID, because some clinics may have more than one. We're looking at for the load number, lot number of both the test and the control BI, the result of the chemical indicator from the test biological indicator, the result of both the test and control BI, and then of course time, date, and initials of those staff who read the BIs once they were incubated, and the contents of the load. But not only is documentation of the sterilization important, but so is maintenance of our autoclaves. And so here's just a sample log of autoclave maintenance for one of the manufacturers that is used within one of the practices. And this particular IFU has specifics for daily, weekly, and monthly maintenance. And a nice component of this log is on the back. The previous IPs had actually gone to those IFUs and clearly outlined what should be performed daily, weekly, monthly, etc. So that was a really nice quick reference cheat sheet for staff. And I'm going to turn it over to Valerie and her love note.
No good deed goes unpunished, we'd say. And so we're working diligently with clinics, especially kind of in that last sprint, preparing for the Triennial Joint Commission survey. And so this particular clinic I'd been out to quite often, and I was looking for a pin. So I was at the nurse's station. I was not trying to even dig around for something. I just opened a drawer to look for a pin and found this. It said, hit it here because of the Dicon folks were here. And it's just a long story, and I'll tell you later, and don't freak out about it. And then I opened up what was in that bib there and found a used nasal spec that we transported to the reprocessing area in a transport bin, not in this bib. But anyway, so just know that as you're working with clinics, especially ones who are not used to having the kind of infection prevention support that you'll provide, you might find that people have to adjust to their new changes, but it's all love, and it will get better. We did want to build in some additional clinic accountability. So what we were finding was that particularly for some of those community practice clinics or clinics that had more of a struggle, we would see them every 6 or 12 months, depending on whether or not they had reprocessing activities. And when we went back, we might find some of the same problems. So we updated our approach in 2024, and that included enhancing our tracer methodology, and this helped build deeper connections with the clinics and know that we were really following along to make sure that things were improved. So the first is that any clinic that scores less than 95% overall compliance for any of the three tracers, the primary, high-level disinfection, or sterilization, if any or all of them are applicable to their clinic. If they score less than 95%, they're required to develop an action planner and submit that back to the quality and safety team. Secondly, if the IPT finds that a clinic scores less than 90% in any one of those tracers, then we'll do a resurvey within 30 days. And then we also came up with a list of questions for each of the tracers to say if any of one of these questions falls out, we're going to resurvey within 30 days because they might overall have a score that's quite high, 97%, but the thing that they fell out on was something that we wanted to have very little or zero risk tolerance for, and that would trigger an automatic resurvey. And so you can see, in 2025, this doesn't result in a lot of revisits. There were only 12 clinics that required a resurvey last year, and that equates to about 11% of the overall clinic practice. I know it's tiny writing on your slide there, but just to kind of give you an overview of what we identified were high-risk practices, that if any one of these things were to fall out, we'll go back. On the primary tracers, those are things that are related to safe injection practices. So any of our questions that deal with labeling of multi-use vials, making sure that dedicated multi-use vials as single use, if it's drawn up in exam or procedure room, and then securement and storage of medications that prevent contamination. Those are all things that if those fall out, we go back. For high-level disinfection survey, our high-risk practices include ensuring that there's complete submersion of instruments, scopes, or probes in an enzymatic detergent, and ensuring all the lumens and crevices come in contact with that detergent. So, if manual cleaning isn't done well, we know that high-level disinfection isn't going to be effective the way it would if we had done manual cleaning appropriately. So we'll go back for those things. If a clinic isn't checking the MEC of the HLD solution with every use or cycle of that instrument or device, then we'll go back. And then finally, if rinsing of equipment doesn't follow the IFU, that's also considered a high-risk finding. And then for sterilization, again, really focused on manual cleaning, making sure that there's full submersion of that enzymatic detergent, that instrument in the detergent, using the correct autoclave parameter as outlined by the instrument IFU, and utilization of a BI at least weekly, preferably daily, and correct documentation of such. So if any of those things, like Brittain mentioned, if they don't document the BI, we have no idea, as the true test of sterility, if that cycle passed, then we'll go back. So after development of the standardized reprocessing tracer tools and using those to gather really valuable data on instrument processing through clinic assessments, we were able to successfully target key areas to improve performance. And we've seen that there's a need for standardization of logs to ensure that IFUs are followed, that those logs, were carefully evaluated. We also wanted to make sure that people had appropriate training. So we developed a 4-hour HLD and sterilization course dedicated to instrument reprocessing. This course is required for all staff who perform instrument reprocessing and takes them through a step-wise approach to ensure consistency and adherence to manufacturer's IFU, evidence-based guidelines, and system policy. And after all of this work, we really note that the key here is communication. There are several clinics such as ophthalmology, otolaryngology, and OBGYN who have invited us back for additional assessments. And those additional elbow-to-elbow support sessions really highlight how important getting out to these clinics and assessing their practice really was to ensure patient safety. By incorporating action planning and resurveying, we were able to ensure compliance with these IP practices. This is just a flyer of our core concepts for cleaning, high-level disinfection, and sterilization course. We now also extend this throughout our network, not to just the single ambulatory practice. And we've updated the course to be applicable to acute care. So we have sterile processing techs in hospitals and infection preventionists in acute care also join this course now. And then, we've heard many times adherence to manufacturers' IFUs is key. And so we want people to be empowered with tools that they need to do a successful job. And so one of those is making sure that they have access to one source and they know how to get to it. So this is just a screenshot of a flyer for how they can get to that resource and look up those IFUs. And really hard work pays off. So there was a 10-day Joint Commission accreditation survey in early 2023 where they sent 7 surveyors. They assessed 64 clinics. And then fast forward about a month ago, they were back this year in 2026. Again, they sent 7 surveyors. This time they went to 56 clinics. And in both of those surveys, there were 0 high-risk infection control findings and 0 widespread infection control findings. So in summary, ambulatory infection prevention programs do share many similarities with our acute care programs, but the differences between the two do exist. And ambulatory settings have unique challenges with resources, space, and staff competency, and surveillance within these clinics is paramount, and developing a structured clinic rounding schedule is key. Creative strategies are needed to engage the frontline staff across many sites. This can be accomplished through an infection prevention liaison program, and that gives you a place for routine meeting and communication with people in your clinics. And lastly, tools and resources to support frontline staff is of utmost importance to ensure consistency in hand hygiene monitoring, device and instrument reprocessing, and other infection prevention activities. Here we've got a list of resources that we used, and we'll turn it over for questions.
All right. Thank you so much, Valerie and Brittain, for an amazing education session. It was incredibly valuable. And thank you for sharing your content and information as well. We are right at the end of our time. So if anybody does have questions, feel free to send them over to Valerie or Brittain via their email or to your APIC Great Lakes Education Council, and we'll make sure that we get those answered and send them out or post them on the YouTube channel. Thank you all so much, and I hope you have an excellent rest of your week. And don't forget to sign up to attend our 2026 conference in October. Thank you.